Thank you. Good afternoon, and congratulations or compliments for your hardiness in staying here all day. If I can make the technology work here. Yeah. There it goes. So the question that I was asked to address in the short time here is how does credentialing research in nursing gain a national focus, or perhaps said a little bit differently, when will credentialing in nursing come to be viewed as a national policy issue that demands and drives sound scientific research? And I would echo, in some ways, the comments that were made before, that you don't necessarily have to wait to have all of the research to make a decision. Indeed, I reflect back when I was CEO of the VA healthcare system in the 1990s and made a determination that all entry-level nurses had to have a BSN, and also committed $50 million to increasing the credentials of those who were already in the workforce over the following 5 years, and that was, 15 or 16 years ago, when the data was certainly less mature than it is today. But it made sense then, and I think it makes sense now. So in thinking about this, developing a national focus and some of the policy and scientific issues, it's probably worthwhile to reflect a little bit on the basics, because I think this actually has direct implications for where this may go. And it is a matter of long-standing national policy that healthcare in the United States is a market-based good that will be provided primarily by the private sector, although increasingly paid for by the government. And it's also become a national policy, certainly over the last several years, recognizing that the quality of healthcare is not what it should be, and that it has to improve, and also that healthcare delivery must become more integrated. And these are important, as I'll come back to in a moment. I think the other thing I would just note here at the outset, that the questions and issues regarding nurse credentialing are not dissimilar to the same question that has come up in lots of other areas over healthcare over the years. Indeed, I reflect back more than 30 years ago when I was asked by the governor to design an EMS system for California. And at that time, we had to set the credentials for EMTs and EMT paramedics and MICNs. Who's an MICN in here? Anyone remember that? They don't even exist, but at that time it was convincing hospitals why they should pay to have these nurses who were trained as MICNs to manage the base stations by which paramedics were calling in. Again, I suppose it really dates me. So as we talk about this, and we go down this pathway of nurse credentialing, I don't think we should lose sight of the forest for the trees, and it gets back to the point that I was making about healthcare in the United States is fundamentally, or at least as a matter of policy, has been determined to be a market-based good. So perhaps the most central policy-related question that research might want to be directed towards is whether credentialing in all of its various forms facilitates more integrated care that yields superior outcomes, that actually has quantifiable value, and that is recognized in the marketplace. And again, some was already commented, have already made that decision based on, in some cases, faith and on a little bit of data. But this is a central research question if we're going to go forward as a national issue. And likewise, the corollary to that is whether nurse credentialing is sufficiently standardized that payers actually know what they're paying for. And again, in a different lifetime running the largest Medicaid program in the country, these types of questions come up, and you want to know whether you are actually getting what you ostensibly think you're paying for. So let me shift gears. In the last bit of time, I'd like to address perhaps two priority research areas, and that's the role of nurse credentialing in providing integrated care, as well as the role of nurse credentialing in driving a culture of quality and medical excellence. I've already noted that integrated care is now a national policy issue, and there is certainly a movement for driving the system, the healthcare system, such as it is, towards more integrated care. Then the question comes up is, what is integrated care? And some have said, well, it's the opposite of what we have. It's you know, the absence of fragmented care. And part of the problem is there is no standardized definition for what integrated care is. I list here three, and I'm not going to read them all off, but those are three attempts to define what integrated care is. And then they're kind of similar, but they're also, when it comes to an operational level, there's some significant differences. The other point, and certainly an issue that the FTC, among others, have been looking at recently, is whether integrated care and integrated delivery systems are the same thing, and they are not. Indeed, integrated care and integrated delivery system are far from synonymous, and it talks about, are we talking about integrated care at an administrative, at a structural, at a quality or other clinical level, and those imply different things and have different precursors, if you will, to operationalize them. Indeed, again, there's no standardized definition for what is an integrated delivery system. And all we have to do is look at, for example, the VA healthcare system in the early 1990s, which was an absolutely integrated from an administrative and financial perspective, but was anything but integrated clinically. If you read the New York Times yesterday, the same issue applies towards the military system. Indeed, you could not get a system that is more administratively integrated than the military healthcare system, but they are certainly not a model of clinical integration. And at the moment, there's certainly no particular model of integrated care that has been shown to be superior to others when certain core functionalities are present. And indeed, depending on how you want to lump them, there's anywhere from 7 to 9 essential core functionalities to achieve integrated care. For simplicity, I've just listed 7 here, but they could be split out as well. And again, you can read them. I'm not going to go through them all. But if you have these core functionalities present, you may not necessarily need to have some other things as far as an integrated delivery system, or at least a traditional integrated delivery system model. So a key policy question, indeed a critical question that could be posed for nurse credentialing research is, how does nurse credentialing either enable or contribute or otherwise support the core functionalities of integrated care, or otherwise facilitate achieving integrated care, which certainly is a national policy goal at this time. The second thing that I wanted to just touch on in the last few minutes is, how does this all relate to achieving medical excellence? And I want to just use a little bit of a case study in this regard. In 2005, the Congress directed that the then historical Walter Reed Army Medical Center be combined with the National Naval Medical Center into a new national military, or the new Walter Reed National Military Medical Center, along with another new community hospital that was being built at Fort Belvoir. They committed $2.5 billion of funding to make this a reality, and they also specified in the law that these facilities would be designed and constructed to be world-class medical facilities. Although, as Congress sometimes is inclined to do, they forgot to put in what world-class medical facility meant, or at least in any sort of operational term. And not surprisingly, concern began to arise that maybe these facilities were not being designed and constructed to be world-class. And so they enacted another provision that, and this time in the National Defense Authorization Act of FY 2009, that there would be an independent review to look at the construction and design plans and affirm or otherwise determine whether these new facilities were being designed to be world-class. I was asked to chair the group that undertook that review. And to make a long story short, after several months of a lot of deliberation with a number of other people, we promulgated what we felt world-class meant, because there was no definition at that time. We looked at things like Baldrige and other schemes that had been used to define excellence, but none of them dealt actually with physical plant in any significant way, and much of what the Congress was concerned about was that. So we defined what we felt world-class meant, and this fell into 6 different domains, 18 different categories, and a longer list of specifics. And this actually became codified and is currently in federal law as to what is a world-class medical facility. However, we also were quick to note that even if all of these conditions were met, that would not guarantee that the facility would in any way be world-class, and that these things were necessary, but they were not in and of themselves sufficient. And indeed, this gave rise to this concept of the invisible architecture, the culture, the values, the emotional climate, and other sorts of soft things that are hard to measure. But it's that invisible architecture that really creates the soul of the organization, and that really catalyzes the synergies that occur between physicians and nurses and other caregivers that leads to the sort of performance that we tend to think of when we think about world-class and that level of excellence. And unfortunately, those things then, 5 years ago, and today remain hard to measure. But the question, and I would posit as a critical research question for nurse credentialing, is to what degree or how does nurse credentialing promote or catalyze the sorts of synergies between and among caregivers and the facility environment and the technology and all the other things that go into a healthcare organization to achieve the level of excellence that we usually think of when we think of world-class. So let me just close with 2 thoughts, and recognizing there's lots more that could be said. But I would ask that as we think about the research questions and how we make this a national or achieve a national focus, one of the things, and haven't heard much about so far today, is what can we learn about nurse credentialing from credentialing in other areas of healthcare? I mean, we have talked about it some, but I think, again, most of these issues are not new. I know that they've been percolating for at least more than 3 decades that I've been involved in healthcare. And there's stuff there that we can learn, and that we should try to harvest those lessons from other areas and apply it to nurse credentialing. And likewise, as team-based integrated care becomes the norm, priority should be given to what's the relationship between nurse credentialing and actually achieving integrated care, as well as creating that culture and the invisible architecture that really drives excellence to a level of performance that might be considered world-class. Thank you very much.
Thank you. Thank you so much. Our final presenter is Sheila Haas, and she's professor and former dean of the Marcella Niehoff School of Nursing at Loyola University in Chicago and the Loyola University Chicago Graduate School of Business. And Sheila is going to share with us a presentation called Getting from Results to Practice and Policy, Implications for Implementation. Thank you, Sheila.